I'm sorry, did you talk to me?
Yes, Amir, yes.
Yeah.
I'm checking
Okay,
whether you are alive or not, you know?
well, I am very much still alive. I'll wait overnight.
Okay.
All right. Some weeks after having a sore throat and a high fever, the patient has developed edema. His blood pressure is increased. Urinalysis volume 450 milliliter per day. Protein is very positive.
How do you call this one? Let's interpret immediately this situation. So if we do have 500 ml per day, oliguria. Now, why is the 500 ml is a clear cut when we're talking about a normal and oliguria? This is somehow the borderline for oliguria. Why?
Because that's the maximal condensation that the kidney can do of the urine. So below that, it's already abnormal.
Almost. Now, let's see. That's okay. So the kidney can concentrate the urine about 4 times. So it's meaning it can produce a 1200 milliosmol urine. So daily, we are going to produce about 600 milliosmol waste particles. Now, these 600 milliosmol waste product, if you consider the maximum concentrating capability of the kidney, can be excreted in 500 ml urine, all right? This is the reason why you said about the maximum osmolarity of the urine. However, not every patient can do this. Now, another very important one. When you do have a kidney problem, first the kidney losing the capability to concentrate, meaning that the kidney cannot produce the most concentrated urine. So it's be less. If this osmolarity, this 1200 milliosmol expressed as a specific gravity, this is about 1035, 1036. So first of all, when we cannot concentrate, relatively this specific gravity, the top, is being less and less and less. Later on, the kidney will lose the capability to dilute, to excrete the free water. The maximum dilution capability of the kidney is 30 milliosmol per liter. So it's meaning 10 times more diluted urine can be produced by the kidney. Now later on, the kidney is losing that dilution capability and the concentrating capability and cannot adjust the osmolarity of the serum. So the urine osmolarity and the serum osmolarity be equal. So 300 milliosmol, and expressed in specific gravity, that's be 1010. Now, 1010, anybody can have 1010 specific gravity. It's meaning that you will drink as much water as much you are losing. So you don't need to concentrate. You don't need to reabsorb the water, whatever you are excreting. Now, this is called isostainuria. So isostainuria, when the urine density and the serum density is equal. However, if you do have a kidney problem, mostly happening in chronic kidney failure, when the kidney cannot adjust the osmolarity, this is called astainuria. Astainuria means that's a pathological condition when the kidney cannot dilute nor concentrate. All right? Clear?
Yep.
Amir?
Yeah.
Okay, good.
All right. There is a protein in the urine. It's 3 grams per day. That is proteinuria. It's quite severe proteinuria. The sediment is 50 to 100 erythrocytes per HPF.
High porphyria.
Leukocytes rarely. Creatine clearance is 30 milliliter per minute. It should be 120, so there's damaged glomerular function. What is the presumable diagnosis?
Now, what do you think? What could be the presumable diagnosis? If you, let's say, summarize these laboratory findings, we do see decreased GFR, decreased urine output. We do have erythrocytes in the sediment. We have high blood pressure, right? And proteinuria. Now, based on these characteristic features. The diagnosis should be
Nephrotic syndrome.
Nephritic syndrome.
Nephritic syndrome.
Nephritic syndrome.
My bad.
Nephritic syndrome. Okay, and when you look at the anamnestic sign, this patient had a sore throat and high fever some weeks ago. So that's possible as a...
Could it be the post-streptococcal group A glomerulonephritis?
That's it, that can be. How would you treat the streptococci infection? Which antibiotic is good for the streptococci infection?
Penicillin.
Exactly, penicillin is still good. Now, let's see. If you do have an increased protein in the urine, how would it look like? So how would you see that your urine has more protein in it?
Maybe the fact that it's not clear, it's not transparent.
Oh, I'm glad that you said no. All right. Because everybody believes that the protein in the urine makes the urine cloudy. Is not true. The protein containing solution is completely clear, crystal clear. If you do have cloudiness or let's see, precipitation, anything in the urine, that usually due to particles, bacteria, epithelial cells, red blood cells, white blood cells, pus, for example, or stone, crystal, yeah, this can cause the cloudiness of the urine. Now, we are talking about the fresh urine. If you let the urine stay at room temperature for a while, you will see that this crystal clear urine be cloudy and that something is floating and precipitating due to the change of the temperature, a change of the pH of the urine. So we always looking at, let's see, the fresh urine. So it's not the protein, it's not the cloudiness of the urine, how the protein can be somehow expected, but foam formation. When you piss and you do see a lot of foam on the top, looks like as a beer on the top of the urine, but that's associated with the elevated protein. And how can you detect the protein at home? So you are suspicious about, oh, do I excrete some protein in my urine? How would you check it?
Maybe using ethanol. I remember from MCB studies, you can denaturate in that.
Okay, let's drink the ethanol, okay? What else? Anybody can help him.
Can we do the urine stick test? But that's not really
Well, do you have
casual.
stick at home? Do you have stick at home?
So that's the problem.
If you don't have any sticks, so don't offer this measurement. Now, what else?
A lot of foam generated by the pissing, maybe.
Okay, this is what we said so far, right? This is what we had about for 50 minutes talk about it. But what else? You want to be very accurate. You want to see that that's really protein. Now, come on, what's going to precipitate proteins?
Heat.
Well, yeah, I was waiting for it. Somebody start cooking the urine. That's fine. Okay, yeah, you can heat the protein and that's will precipitate. What else? Sanjay.
Salts.
pH. Somebody said pH. Who said it?
Yes, sir.
Okay, and how can you change the pH?
I don't know. Add acid or base.
Okay, let's see. Acid, vinegar, that's it, acid. Don't use alkaline solution because alkaline solution is going to dissolve the protein. All right, so what you use, for example, as a tube cleaner, they has very high alkalic solution and that dissolves, let's see, the protein. Okay, so make acidity, dropping some vinegar into the urine, and when you do see some cloudiness or some precipitation, that could indicate the presence of the protein. Okay, now you can use the Mr. Muscle or the tube cleaner, for example, to detect pus. What they used to use, this was a dial test, they use potassium hydroxide and they put into urine and shake it. And when they do have the foam formation, now that indicated that they do have, let's see, pus in this urine, but now they are using the dipstick, so you don't have it, this kind of problem. Very good. Any question? Thank you, Amir.
I have a question.
Okay. Amir slept again. Yeah.
No, I'm still here. I just don't know whether I should turn it off or not.
Okay, you can turn off or mute yourself. Okay, Sanjam.
So you said this is a nephritic syndrome, but
yeah.
how would we explain proteinuria here?
Well, proteinuria can be accompanied with nephritic syndrome as well. So it's not only due to the nephrotic syndrome, because when you do have the inflammatory reaction, that inflammatory reaction is going to damage the glomeruli as well. So you can have a higher protein excretion. And plus the protein can be due to the inflammation and the permeability changes as well.
So here we wouldn't say that we can see both nephrotic and nephritic syndrome.
No. This is a nephritic. That's a glomerulonephritis because it's not only the proteinuria. If you do have red blood cells, especially when you do have red blood cell cast, and that meaning you do have a bleeding that originated from the glomeruli, and that's glomerulonephritis.
Okay. So we see if there's hematuria or inflammation going on.
Exactly. And basically the patient who has glomerulonephritis, usually the CRP level increases, usually they have fever, they have a sensitivity around the kidneys on the back, yes. And very importantly, the volume of the urine is going to decrease. Okay, and the blood pressure increases. Okay, now Sanjun, stay here and let's read the second question.
Laboratory findings of a patient with massive edemas. Serum total protein 40 grams per liter.
What is a normal?
I think it's normal.
Nope.
No, it's not. Oh, it's a normal value like 60 to 80 or something?
Yeah, 60 to 80 and 40 is good for albumin, another total protein. Okay.
Serum cholesterol 10 millimole per liter. That is high.
Good or yes, it's high. It's very high. Okay.
Erythrocyte sedimentation rate 28. I have no idea if that's
millimeters per hour. What is the normal value? We haven't studied yet. What is the normal value?
Less than 20.
Yes, for a girl less than 20 and a man less than 10. Okay. Blood pressure is?
Blood pressure is 120 over 80 millimeters of mercury, which is normal.
Okay.
Urinalysis quantity, 1,800 milliliters per day. It's a bit high.
Why?
Oh, it's not high, actually, no.
It's not high. If you do have more than 3 liters per day, no, that can be polyuria.
No.
But not this one, okay?
Protein level, 12 grams per day, very high.
No, that's too much, okay?
Yeah. Sediment, 1 to 2 leukocytes over, I don't know what that stands for, but.
High power field. High power field means that you're using that was the gold standard evaluation, but today they are using instruments, and this instruments is going to measure the sediment. They are going to aspirate it and dissolve it and after count it. Now what high power field means that you're using a tube that the magnification of the tube is 40 times, plus the ocular is about 10 times or 15 times. So that meaning about 400 times magnification. And whatever area you can see and want, that's a high power field without changing, let's say, the view of the microscope, okay?
Yeah.
So that's meaning that as you listened or as you heard it, about up to 2 white blood cells and the same about red blood cells per high power field, that can be completely normal. And ladies usually a little bit higher, okay? And a very important one.
Erythrocytes, rarely a lot of hyaline casts.
Hyaline cast. What is the hyaline cast?
It's made of proteins, and it can be seen after reabsorption of water.
Exactly. This is what we do have when the patient has a very high amount of protein in the urine. So when they have proteinuria. Now, nephrotic syndrome can be due to a lot of things. Minimal change diseases, for example, the diabetes will cause later on, or multiple myeloma, for example, that can cause, or a lot of other diseases. So that can be associated with nephrotic syndrome. And for sure, after when you find this kind of clinical signs, you have to be very carefully evaluate the patient. Usually you have to take the biopsy and let's figure out what the reason why the patient has a very high protein excretion. All right. That's it. So this was the first two questions about differentiating the nephrotic and nephritic syndrome. Okay, now let's see the next one. Buyong.
Yes. A febrile patient complains of lumbar pain. So I can detect here, usually lumbar pain, it's retroperitoneal. So I guess it's the kidney problem. That's where we mostly have.
Yeah, but lumbar pain can be due to, for example, if you do have a discus hernia, for example, or back pain or anything, muscle pain, a lot of things that you have to differentiate. Back pain can be, for example, if somebody has a kidney stone to develop or tumors, a lot of things can cause lumbar pain. But here we do have a febrile patient.
Febrile, yes.
Okay.
That's another hint, I think. Febrile usually means feverish. So I will connect it to the information that I was given. So the protein is positive, but it's not as severe as what we have seen in the question before, and pus is even more. So pus and febrile, we can think about any infection.
All right.
Sediment, a lot of leukocytes, which is very supporting our thought that it can be an infection and inflammation.
Yeah, the pus, usually if you do have pus, it's meaning that you do have a lot of white blood cells as well, okay? Okay.
Sorry. Sorry. Oh, sorry. Sorry.
Okay. Yeah. She disturbed by a dog or she disturbed by
sorry,
her sister?
I have a door call. I'm sorry.
Okay.
Sorry. Okay. Epithelial cells, a lot of bacteria. So we can think that this. So we can think that this is bacterial infection, and we have leukocyte cast.
Okay, very importantly, because if we do have one leukocyte cast, that can indicate immediately pyelonephritis. So let's remember, if somebody has only one leukocyte cast, that can be immediately pyelonephritis, right? So usually pyelonephritis is due to the ascending inflammation, but not only the ascending inflammation can cause pyelonephritis, blood transmitted one can cause a lot of other things. As you do see here, the creatinine clearance a little bit altered, not too much.
A little bit, yes.
Yeah, the ESR is elevated, but due to the pus and due to the leukocyte cast, immediately you can diagnose that this patient has pyelonephritis. What kind of evaluation you do if somebody has this pyelonephritis?
I would go for the cause of the inflammation. I would, so bacteremia, and I would go for which bacteria. So I would go for tests.
Okay, you have to do that. Okay, what else?
For which type of bacteria.
Okay, what else?
And what else?
Ultrasound should be used as well. And you should start treating the patient with antibiotics and at least for 2 weeks. So it has to be very carefully and very aggressively treat the pyelonephritis, because if you do have a long-standing inflammation in the kidney, in the pylon, that can damage the kidney and can cause kidney, let's see, scarring of the kidney, and kidney failure can be due. Okay, good. Frida, Astrid, are you here?
Yep.
Okay, welcome back. All right, now you have the fourth one.
Okay, so the laboratory findings of a patient include the following: urinalysis, sediment 3 to 5 erythrocytes.
So it's a little bit increased. Oh, by the way, we do have macroscopic and microscopic hematuria. What is the difference between these two, this terminology?
I don't know.
Yeah, you can say it. Macroscopic means you can see the color in the urine. Microscopic, you cannot. Only by microscope you can, let's see, test it. And my next question is, how much blood you should have in the urine to see the color? That's a more tricky question. See, anybody can help her. Amir.
I'm still here. I don't know the answer.
Maybe 3 grams?
How much?
More, over 3.
Over 1 ml or over 1 ml per liter. So if you put 1 ml blood into 1 liter of urine, you can see the color. So it doesn't need to have a huge amount of blood to see the color, all right? So here we do have a microscopic hematuria because the red blood cells elevated and leukocytes not, and erythrocytes are isomorphic, meaning intact. So they are not damaged. Dysmorph red blood cells means glomeruli origin blood, because the red blood cells push through, let's see, the tubular system, the collecting duct, the mechanical, let's see, forces, plus the osmotic gradient, because you are going from the diluted to the concentrated back to the dilution. So that's going to torture, that's going to damage the red blood cells. And this is why they're dysmorphic. Okay, there are minimal proteinuria, okay, and urinary protein electrophoresis doesn't show any selectivity. What the heck does it mean? Selective proteinuria.
So it doesn't show any specific proteins? Or?
That's great. Now, what kind of protein is specific for glomeruli proteinuria?
Albumin?
Exactly, very good. And tubular cells? If you do have
low molecular weight proteins.
What, which one?
Low molecular weight.
Very good, very, very good. The low molecular weight protein. And not selective means you do see everything from the low to the high molecular weight protein, and usually that's associated with inflammatory reactions, okay? All right, go on. So, and the creatinine clearance is 120 ml per minute. So what do you think? This glomerular, what is this one? Is the glomerular hematuria or urinary tract bleeding?
Is it urinary tract bleeding?
Exactly, because that's isomorphic, exactly. What could cause urinary tract bleeding?
Some sort of damage.
Stone, what else?
Tumor.
Tumor and?
Cystitis.
Foreign body.
Cystitis. Foreigner body, Jesus Christ, what you are doing. Yes, it can be, it can be, but foreigner body. Okay, it's happening. Some patient likes putting everything into urethra, so it's okay. All right, so these are those things. That's a urinary tract bleeding that can be inflammation, stone, tumor. Good, very good. Okay, let's move on and let's pick another one. Fadl,
Yes, okay. After receiving a massive dose of aminoglycoside antibiotic, a patient with no prior symptoms of kidney disease develops a body weight gain of 3 kilograms over a period of 3 days. He does not void urine spontaneously. Total volume of urine collected is 200 milliliters per day. Other laboratory results: serum creatinine is 440 micromole per liter, serum urea is 28.5 millimole per liter, plasma potassium 6.2 millimole per liter. Okay, so we can see that he had an antibiotic treatment, a massive dose.
Yes.
Of aminoglycosides. There's a significant weight gain. From the urea, we can see there's anuria.
Okay, very good.
There's an increased creatinine in the serum. We have a very high serum urea and also a high serum potassium.
Okay, what do you think how the blood pressure changed in this patient?
I think it increased.
Increases unless the patient has a septic shock. Okay, but this is increased. Okay, and what causes this acute kidney failure?
I think it's like it's because of the very large antibiotic doses. So it can be like the toxicity from the antibiotics.
Okay, why the kidney is sensitive to aminoglycosides?
Is it
because the kidney has like, it plays the role in filtration. So when it comes
wait, okay, Amir,
is it because something with the antibiotics that are excreted in the non-conjugated form?
Doesn't matter which
tubular cells.
Okay, the tubular cells going to excrete the antibiotic. All right, so the metabolism of the antibiotic goes through the tubular system. Now, if and especially it's going to be accumulated inside the tubular system. So when do they use aminoglycoside? Usually this is the last when they start using this aminoglycoside, because very aggressive antibiotic, very good one, but aggressive and has a toxic effect. Usually they're using together by measuring their serum concentration. And in kidneys patient, when we do have a problem, for example, hypoxia or any other things due to, for example, septic shock, relatively less oxygen goes to the tubular system. So that can somehow alter the tubular function, plus the aminoglycoside, and that can cause acute tubular damage. Now, what kind of cast can you see in the sediment after having a tubular necrosis? It was in this little presentation, brown granular cast, brown granular cast. So that's meaning that the tubular cells that's damaged, necrotized, it gets into the tubular system and forming the cast. And the color is brownish and they're granular. It looks like a little granules that you do have. Okay, good. So that's an acute kidney damage, acute tubular necrosis due to the aminoglycoside antibiotic. Very good. Okay, let's move on. Wow, that's a deja vu feeling, at least to me. Okay, Henrik.
Yes.
All right.
So the serum glucose level is 15 millimoles per liter in a diabetic ketoacidosis. Glomerular filtration rate is markedly decreased, 20 milliliters per minute.
Yes.
Tubular function tests are negative. No glucose can be detected in the urine by repeated tests. Let's see. So we have a decreased GFR.
How is it possible? We had identical question in the previous semester. Can you remember?
Yeah, so we have a problem with the filtration of the glucose. So glomerular nephritis.
No, we don't know what we do have glomerulosclerosis possible in diabetes. So what will happen right here, because the filtrated glucose is determined by the serum level of the glucose, the GFR, and the tubular reabsorption capability. So if you do have, let's see, a high level in the serum, and everything else is normal, you can have glucose in the urine. This causes osmotic diuresis. However, if you do have a problem with the GFR, you do have less filtrated glucose that the tubular transport system can handle it, and that won't be glucose in the urine. And that could happen, for example, the late phase of diabetes, because diabetes can alter the kidneys as well. How would you check for the diabetes-induced kidney or nephropathy? Do you remember?
I can't remember how you would check it.
Anybody else?
Maybe because it affects the small blood vessels, or we can do some angioplastic measurement, or even
no.
We check the glucose and level in the urine and also the blood.
No.
Sorry, what was the question again?
Okay, how would you check the diabetic nephropathy in diabetes or any other, for example, hypertension-induced nephropathies or diabetes-induced nephropathy? How can you estimate the grade of the damage?
Should we check angiotensin?
Okay, it's only once. Ali Reza?
With the Doppler ultrasound?
Nope. Amir?
I was going to say ultrasound.
Nope. Sanjan?
Did you hear that I said angiotensin?
Nope.
You check the creatinine, so the GFR?
Okay, you can check the GFR, but they are not checking the GFR because there's a creatinine has a disadvantage, because first of all, it's going to depend on the mass of the muscle, the diet and the genders and everything. Plus, it's overestimate the GFR because about 10% of the creatinine excreted by the tubular cells. However, nope.
Is it the albumin concentration in the urine?
Yes. Albumin, microalbuminuria should be checked. So albumin, if you do have more than 300 milligrams albumin per day, that's not good, or 30 milligrams per millimole creatinine, that's bad. And that's associated with the side effect, the high blood pressure, everything. Okay, so don't forget microalbuminuria should be checked. Okay, good. Now let's see the last one. Who wants to do the last one? Okay, who hasn't said anything about it? Let's see, Sabine or Subin.
Yes.
Okay, how do you pronounce your name? Subin or Sabine?
Subin.
Subin. Okay, let's read it.
So laboratory findings of a patient: urinalysis, color yellow, transparency turbid, quantity is 400 milliliter, and present 1,600 milliliter per day.
Okay.
Specific gravity 1,022. Protein 50 milligram per day.
All right.
Pulse is positive and blood is also there, and glucose is negative, acetone is negative.
Okay. All right, go on.
And UBG, where is it? Is normal, and bilirubin is negative.
Okay.
Urinary sediment is 20 to 30 epithelial cells, 30 to 40 white blood cells per HPF, and 3 to 4 RBC per HPF.
Okay.
And further data: body temperature 38 degrees Celsius, white blood cells 12 gram per liter, red blood cells 4.5
is normal.
Okay.
ESR is normal, creatinine clearance is normal, and cultivation of E. coli is not normal. All right, how much protein we can have in the urine per day? Anybody can help her?
3.
How much?
250 milliliters.
Up to 150 milligram per day, 150 milligram per day. During pregnancy, that can be 300 milligrams per day. All right, so that's the normal. So it's completely normal. All right, that's completely normal. Now, what we do have here, that's an inflammatory sign. We do have a lot of epithelial cells, white blood cells, and the little red blood cell increased, fever, white blood cells. So possibly we do have leukocytosis or granulocytosis because that's an acute one. And ESR is okay. And what can be our diagnosis right here?
Infection.
Yes. What kind of infection?
Maybe urinary tract infection.
Yes, cystitis, lower urinary tract infection. Yes, that's it.